Hi, everyone, again. Thank you again for joining. We're just going to give it a minute or two more for more attendees to trickle in. Please continue to keep yourself on mute, and you may directly message our hosts, Niquan Davis and Deborah Bachu, if you have any technical issues. Thank you for your patience. All right, good morning, everyone. Welcome to the session on resuming in-person data collection during COVID-19, hosted by the Population Council. My name is Corinne White, and I'm with the Poverty, Gender, and Youth Program at the Pop Council. We are so excited today to welcome colleagues from across the globe. And we do have a very packed session today of extremely busy people, so I'd like to go ahead and get started. And I'm going to introduce my colleague, Twy No, the Director for the Poverty, Gender, and Youth Program at the Pop Council. Twy, over to you.
Good morning, everybody. Thank you so much for joining us this morning, and good afternoon and good evening to everybody. My name is Twy No. I am the Global Director for the Poverty, Gender, and Youth Program at the Population Council. It's a great pleasure to see everybody on this seminar. We're in for a treat today. I also want to extend my warm welcome to and thanks to an impressive group of research leaders and scientists who are going to be our panelists today from APHRC, the London School of Hygiene and Tropical Medicine, Johns Hopkins University, IPA, ID Insight, and the World Health Organization, and of course my wonderful colleagues at the Council as well. So today we're going to focus on resumption to in-person data collection, and I just want to have a couple reflections on what we have done within the last 6 to 7 months. It's been really great to see the scientific community has come together to generate relevant and policy timely data to both understand the disease, the pandemic, but also its impact on the lives of people. And in early March and April, many of us had to resume to mobile data collection in order to protect the safety of our team members and the communities that we serve. However, there are some shortcomings and biases with that methodology of mobile data collection. And as we continue to learn about the pandemic, adapt to social distancing, and understanding that the pandemic will be with us for quite some time, many of us, scientists, organizations who focus on in-person data collection are figuring out ways to ensure safety and how do we resume to in-person data collection. So today is great to bring together this group of research leaders and scientists to really think about 3 things to really gather institutional perspective from research stakeholder on resuming in-person research activity during COVID-19 pandemic, and how do we adapt that as the pandemic progress and as at different outbreak slow down or flare up, and assess the different epidemiological, ethical, and as well as practical consideration in terms of budget, staffing. How do you keep social distancing for determining where and when in-person data collection may be possible? And then the third is to create a momentum for cross-institutional discussion, alignment, and advocacy for establishing global guidance and standards for in-person research in pandemic-affected area. So I just want to overview the agenda quickly. For the first session, we will focus on the three main ethical considerations: the epidemiology of the disease, some ethical consideration, and the practical of resuming back to in-person data collection from colleagues from the London School of Hygiene, Johns Hopkins, and Population Council, as well as colleagues from ID Insight. And the second section will be more practical, bringing in case example that institutions are experiencing right now as they beginning to put it into measure on how to resume to data collection. And then the third section, we will have some kind of wrap up and just kind of a synthesis of the seminar today. And there is no really fixed outcome because we do see this as the first of many discussions to come. And we hope that the rich discussion that we'll gain from the meeting today will be the next steps for additional cross-institutional learning, as well as a call for action to what the scientific community should be considering moving forward. So welcome, everybody. I'm really excited. Thank you to our panelists, and especially thanks to my colleague Corinne and Paul for organizing all of us. Over to you, Corinne.
Thank you so much, Twy, for the warm welcoming remarks. As Twy noted, our first session will lay out the key considerations for resuming in-person data collection, and each presenter will speak for 10 minutes, and we will have a moderated discussion afterwards. So I'd like to introduce our first presenter, Dr. Bilal Ivan, who is an associate professor at the London School of Hygiene and Tropical Medicine, where he focuses on health system strengthening and program evaluation. Next, we will hear about ethical considerations from Megan Singleton, who is the Associate Dean for Human Research Protection and the Director of the Human Research Protection Program at Johns Hopkins University School of Medicine, where she directs the Institutional Review Board system. Finally, we'll hear from Dr. Paul Hewitt, who is my colleague in the Poverty, Gender, and Youth Program at the Population Council, and also the Technical Director for the Breakthrough Research Program, which is the flagship USAID social and behavioral change research activity. Paul will present on the practical considerations for resuming in-person data collection. Finally, following Paul's presentation, we will hear from Michelle Hinden, who is the Reproductive Health Program Director at the Population Council, and Ruth Levine, who is the CEO of ID Insight, a development economist and an expert in the use of data and evidence for decision-making. Okay, I will turn it over to Bilal to share his screen and get us started.
Bilal, you are on mute. I unmuted you.
Okay, thanks. Okay, good. Okay, I hope everybody can hear me clearly. First, thank you for giving us the opportunity to share our experiences. My sort of a brief talk will focus on two issues from the epidemiological perspective. First issue is around the safety issue, safety of the field staff who are engaging in the data collection in person, and also these field staff in reality could act as a carrier and could introduce sort of infections within the populations they are collecting the data. So this risk is from the two perspectives, from the population as well as from their own safety. And also COVID-19 situation poses a lot of measurement challenges for the other ongoing researches, where behaviors and health conditions probably needs a careful assessment as compared to the when the in circumstances are normal. Okay, so I will be sharing my thoughts based on the work currently we are doing. We are working in 3 contexts: Nigeria, Pakistan, and Ethiopia. They are quite diverse contexts. If we look at Nigeria, with respect to response for the COVID-19, the guidance for the public health engagement and for the services providers is very good, but it's sort of implementation is quite weak. While in Pakistan, the guidance as well as implementation is good, as well as there are extra workforces available in the form of logistics managed by army. While in Nigeria, the guidelines and the support available for the general public and service provider is quite limited. But on the other hand, government response is so strong that right from the beginning, they introduced emergency. So all the services were aligned. So these are 3 different contexts in Nigeria. Hello. So in Nigeria, we have our work focuses primarily on household level data collection, especially focusing on women of reproductive age and the children under 5. In Pakistan, our work focuses primarily on health facilities and in the context of labor room services. While in Ethiopia, we are focusing primarily on data collection on the health system managers. So you can see that we are working in a quite diverse context as well as the diverse mode of data collection in person. And all these activities of data collection has already resumed, and we are trying to resolve a lot of challenges that I'm going to share with you. Okay, now the first point, which is about the safety. I think in order to understand the safety of the staff as well as the population, it is important to first understand the risk assessment, that how the risk assessment. And I mean, all of you know much better than me that the classic sort of epidemiological try to understand the natural progression of the disease, and also all the 3 major components like environment, carrier, and the host. So understanding of all these factors is a key in order to predict the risk. But as the COVID-19 is a new condition, a lot of information on these aspects is quite patchy. And usually the tools of the trades are when you do the risk assessment, or the prediction is usually done by the forecast modeling. And there are several sort of perspective or techniques are available through which those sort of predictions can be made. In addition, all these models require a lot of parameters. The more good quality parameter you can include in them, the more better prediction you can make. And these parameters include from understanding of the disease itself, health infrastructure, preventive measures, and policies. So you can see that a lot of elements interplay with each other in order to make a better risk assessment. Now, I can give you the one example which is very pertinent. And here you can see that it's an example from China, where all 4 techniques are used, and each technique has used different data sources, different parameters, and in fact, they are ending up having a different outcome of interest. Now, this is important that to consider that whenever we do the risk assessment and try to look towards the model, it is important to consider that not all models are equal, and their nature and their objectives are different. So I can take you the example that how we face this challenge. I mean, the pandemic was declared on 11th March. In March, Ethiopian government has started strict measures. We were about to go into the field with our intervention. All the staffs were hired and the data collection was supposed to start in April. and we have to stop every field activity because the projection was that there will be first 1,000 cases in the beginning of May. 3 months passed and that target was achieved because I think at that level we couldn't sort of able to analyze that this is a number for a cases and it doesn't take into account the intensity of the condition as well as the health infrastructure or government response. So in August, we reactivated the process and that resulted in a lot of negotiations with the government and the collaborative institutions, and which ended up a lot of redefining the activities so that we can minimize the risk and we can achieve our objectives. One important learning lesson was that this was in the current circumstances, conducting research will be expensive and slow process, but it's going on. Okay, now a few measurement issues which I thought very interesting, which we learned from sort of our experience. First is symptomology of COVID-19. In Nigeria, our staff are supposed to check their own symptoms daily basis, as well as the household they visit. They have to ask the questionnaires through questionnaire that is there any active symptoms of COVID-19 available. If yes, then they will not interview or contact that household. But that study is one of the main objective of that study is to assess occurrence of malaria symptom in last 2 weeks, which means that the symptoms of malaria versus COVID-19 are quite overlapping. And if we strictly follow the safety measure, we ending up having a quite underestimation of our outcome of interest. So that we try to resolve and come up with a compromise to have a exclusion of the household on the multiple symptoms of the COVID, and then carefully ask the nuanced question on the pattern of fever. Another issue which we noticed that is a change in the service provider behaviors in the context of COVID-19. In Pakistan, we are supposed to collect data in the labor rooms. But due to the COVID-19 sort of a dimension, the interaction between a labor room staff and the pregnant woman is dramatically changed. So in order to assess their actual behavior, which they are going to demonstrate in their normal sort of a pattern, it is quite impossible. So instead of doing direct observation, we ending up developing more sort of a clinical scenarios as well as the more qualitative approach. So because in order to capture their sort of a true sort of a intention of the behaviors they would practice in the normal days. In Nigeria, in Ethiopia, one of the technique we were planning to do with the district level managers, that the self-administrator part of the interview, that we will hand over the tablet to them and they will self-administrate the questionnaires. But in the current circumstances, we don't want to exchange any material with the respondents, any questionnaire in paper form or tablet form. So we have to revise all the methodology so that it can be collected in a more sort of a oral manner. Okay. So in order to just to summarize quickly that safety of the staff and the safety of the population is very important, but all the tools available to assess the risk needs to be carefully assessed, and the one shouldn't solely rely on that. I think it's important to actively engage with the Ministry of Health and local collaborative institution and take a collaborative plan of action. And also, I think last but not the least, ongoing risk assessment is very important, and flexibility on the part of researchers so that they can modify their research plan on ongoing basis. That was a quick sort of overview. Thank you. I think my time is also up.
Thank you so much, Bilal. Turn it over to Megan.
Megan, you are on mute if you already started speaking. I've unmuted you.
Thank you so much. I appreciate it. So thank you very much for the opportunity to be here with all of you today to speak a bit about the ethical considerations for resuming research in the era of COVID-19. I think as we've already heard this morning, there's many challenging considerations to discuss, and I appreciate the opportunity to think through how we can apply the ethical considerations to practical circumstances. So I'll be speaking a little bit today about some of the framing for how we might think about this from an ethical perspective. As many of us know, there are various organizations who have adopted different phased or tiered approaches to the ramp down or restart of research. And the phased plans can include many different factors or considerations, including local incidents and restrictions, potential exposure risks, both for research participants and others, system burdens, including whether the actual physical space where the research activities may occur can be accommodated to provide a safe space for research participant interactions, as well as the availability of personnel to engage in those interactions, whether the specific studies themselves have the potential for direct benefit, and the vulnerability of the participant populations that are being targeted to be included in the research. So when we think about ethical decision-making regarding the process of restarting research, I do think the framing of the Belmont Report, which is one of our founding documents for human subjects protections, offers actually some really helpful considerations. So first, persons are treated in an ethical manner, not only by respecting their decisions and protecting them from harm, but also by making efforts to secure their well-being. And moreover, the obligations of beneficence affect both individual investigators and society at large, because they extend both to particular research projects and to the entire enterprise of research, really calling us to think about this as a collective. And rather than take an individual project-specific approach, lean towards exactly what I think the purpose of the webinar is today, spark a discussion about how we can approach these issues responsibly as a collective research enterprise. So what is our responsibility when it comes to thinking ethically about risk minimization and the risk to benefit ratio and whether we can establish if it's reasonable? In the United States, the Common Rule sets forth specific criteria for IRBs or ethics committees to consider in relationship to risk minimization and the reasonableness of the risks in relationship to the benefits. And we must consider both whether risks are minimized, and in consideration of that, look to whether or not the procedures do not unnecessarily expose participants to risk, and also looking at whether risk to subjects are reasonable in relationship to the anticipated benefits, if any, to subjects, and the importance of knowledge that may be expected to result from the research. Also, IRBs or ethics committees, when they're thinking about the approvability of the research, must specifically consider the vulnerability of populations and consider whether they may be vulnerable to any coercion or undue influence, and in those cases, ensure that there are additional safeguards in place to protect their rights and welfare. So how do we think from an ethical framework and about balancing the risk in the era of COVID-19 when COVID-19 exposure itself is not a research-specific risk? While it may not be a research-specific risk, if we look at the framing of the Belmont Report, we still have an ultimate responsibility to safeguard the rights and welfare of research participants, suggesting we have an ethical responsibility to mitigate the risk of exposure, particularly if it could be introduced or enhanced by the research interactions. We've seen many people initiate risk mitigation strategies, but as we've discussed and are discussing today, those include components like reducing in-person interaction or switching to modalities such as remote data collection mechanisms. And there is a pressing concern that switching to those modalities might actually create inequity in inclusion in research. So in terms of risk mitigation strategies, we might also consider whether the research may need to be revisited to look at the eligibility criteria and consider whether there may need to be adjustments in light of those that might be at greatest risk from COVID-19 exposure. We can also certainly minimize risk through use of screening and appropriate procedures, such as use of safe PPE, et cetera. But it's important that we consider that in the risk minimization and risk to benefit ratio assessment, we do have a new factor to consider. And the COVID-19 research risk exposure is something that needs to weigh into our considerations as we resume in-person research interaction. The challenge, and Bilal mentioned this, is that the information is dynamic and it changes constantly. So unlike typical risk assessments where we are making a definitive judgment about whether or not the risk is reasonable of a specific research study and whether or not the risk to benefit ratio is in fact reasonable, assessing risk in our current context actually is a continual activity and not a fixed time point. We know that risks may be uncertain and unpredictable, and we have an ethical obligation to continue to evaluate when those risks are changing. We also know that local context considerations are especially important in this time, now more than ever, because each location's circumstances are unique, dynamic, and they're evolving all of the time. So especially for researchers who are doing multi-site research in many different locations, an ethical plan and approach to resuming research activities may include adjustments for variability from site to site. One other consideration that has been raised is we know that there's uneasiness about resuming in-person research activities, and there's uncertainty about whether we'll be able to achieve enrollment aims when participants may be hesitant to resume in-person interaction. In that case, we have to think about the ethical nature of initiating the research if we won't be able to achieve the research aims. And then finally, and Bilal alluded to this as well, in the research, when we consider the ethical approach to resuming research activities, we have to think about this holistically, not only about risk minimization and the burden and benefits of research to participants, but also to others that may be impacted by the resumption of research activities, including study team members, healthcare workers, individuals who may share a household with a research participant, and the communities in which we may interact. So I look forward to discussing further how we can apply these framing and thinking about some of these ethical issues to the practical resumption of research activities, and considering the application to some of the great work that folks are already doing in this space to work on that resumption. Thank you for the opportunity. I look forward to our further discussion.
Thank you so much, Megan. We'll move on to Paul Hewitt.
Great, thank you very much. So good morning, good afternoon, and perhaps good evening for those who've joined. Thank you very much for attending our webinar. I'm going to talk about some practical considerations for resuming data collection during COVID-19. And as the previous presentations suggest, these overlap and have interrelated connections. But my work is really going to, or my discussion is really going to focus on the practical aspects, and what I mean by practical is in practice of implementing field work. And so in many cases, this assumes that the alternative research plans have already been considered and some of the epidemiological and ethical considerations have already been started. Are there other considerations? We have to keep in mind that there are a lot of different considerations besides these, and hopefully in the next session, we'll have some applied examples where some of these other considerations will also emerge. So I want to talk about, in a heuristic way, the research process between donors, the research team, and institution, the various ways in which COVID considerations will come into play. There's the interaction between the donors and the research team at the initial phases and in the initiation of the research in terms of proposal and how the work plan is developed, budgeting, timeline, and reporting, as well as various opportunities for interaction and engagement with the research team and institutions through the protocol process, budgeting, as well as development and approval of instruments and SOPs. And fortunately enough, a lot of these mechanisms can be leveraged, as suggested previously, for the additional considerations for COVID-19. And what I'd like to talk a little bit about are the risk mitigation strategies, considerations during implementation of training and fieldwork, the monitoring and reporting issues that arise, as well as adaptation and timelines that may be expected, and some implications for additional or unexpected costs. So in terms of mitigation strategy plans, as was suggested by Megan, we have to consider the protection of the institutional and fieldwork staff. We have to consider protection of participants, as well as protection of others in the community. And to do that, we have to also consider national, state, and local guidelines for protections and for COVID adaptations, global guidance that are provided, as well as the institutional guidance from our respective IRBs, decision makers that have been particularly assigned to consider COVID re-engagement, as well as any management of the project or of the organization and their guidance. So some of the areas of implementation where we have to consider risk mitigation are in the early phases in terms of facilities, all aspects, in terms of training, including all aspects of facility in terms of size, spacing, and ventilation, food and drink preparation, as well as screening of the training participants and the staff prior to and during the training, and any behavioral messaging that would take place to staff or to participants prior to training and during training. We have to consider during implementation the potential risks involved with transport and travel, and that could be to and from work or to and from the training, to field sites with the field teams, as well as to the households themselves, and any international travel of PIs or others to the field sites. And also in terms of the fieldwork themselves, we have a lot of behavioral considerations around the potential risks to staff and between staff and between staff and participation, and have to consider various risk mitigation strategies to alleviate those risks. And it'll be very important in the context of those guidelines that are provided, whether they're national, global, or institutional, how to prioritize those risk protection behaviors and to standardize how they're implemented and how they're defined for proper implementation. So the Population Council has developed a matrix type approach for developing risk mitigation plans that considers the activity in various specificity levels and assigns the likelihood of risk to that. And it'll be important for all institutions and PIs and research teams to think about standardized definitions of risk assessment. In many cases, these will be very subjective, but at least understanding the parameters from study to study will be a critical, important point within and across institutions to understand how those risks are assigned. Specific actions are noted in terms of how to mitigate those risks, as well as the frequency of review of those plans and their outcomes. As such, regular monitoring and reporting of events will be very important, and as suggested by Bilal, as well as the discussion prior to this one, we have to think about monitoring the epidemiological context, policy and guidance changes that may occur at various levels that are particularly related to the context in which we're operating our research study. We have to also monitor staff compliance with SOPs around behavioral, risk reduction strategies, and consider the likelihood of behavioral compliance for each one of these, and also potentially mitigating strategies if behavioral compliance is low or not as high as we prefer. We also want to think about and pre-plan reporting of adverse events, who to, when, and how that reporting will take place, including exposure to COVID positive cases, symptoms of COVID reported by staff or by even participants during the research process, any positive test results if testing is used as a method for evaluating staff during the implementation, as well as any community or household response from any implementation during the COVID period. And what this may imply that we have to be ready for adaptations to our implementation and to our timeline, and suggestive of that is piloting protocols and standard operating procedures to create adaptive planning, and in that process assess our compliance and adherence to those standard operating procedures and behaviors that we hope to achieve risk mitigation with, assess community reaction, as well as the quality of information flows that are occurring in our monitoring and reporting between staff, supervisors, the research PI or investigators, as well as the institution and IRBs and others. We should consider study stop and restart scenarios, including if-then scenario planning for stopping the study when adverse events occur, as well as when and under what scenarios restarting would occur given a potential stoppage. We also have to think about discussing and having in our back pocket Plan B scenarios with our donors in terms of reframing our research if, as Megan suggested, it cannot be conducted potentially for ethical reasons, by example. And so that means coming up with alternative research questions to the ones that we already posed, as well as alternative research design options, including remote data collection as backup. However, as we all know, this would have implications for the effort that it takes to implement the work, our timelines, and the quality of data, as well as the potential costs, which also have to be considered in our Plan B scenario. So some of the cost considerations, and these are just a listing of a few of the most pertinent ones, are the potential add-on of potential protective equipment, additional training costs due to increased size or timelines with venues, as well as the purchase of PPE for the training, any educational materials that are provided to either participants and the staff that may be COVID specific, as well as what would naturally be expected in terms of the increased transportation cost, which is a large fixed cost in implementation, particularly as we space out interviewers in vehicles and thinking about alternatives in addition to vehicles to create a context in which the risk of staff-to-staff transmission is minimized. It may include cleaning and sanitizing of materials, vehicles, and rooms on a regular basis, as well as the implication of costs for fieldwork stoppage. And all of this are under the umbrella of a potentially additional level of effort and institutional overhead related to planning and procurement for COVID, delays due to COVID, as well as field staff and sick time that have to be worked out and thought through, hopefully at the outset with donors in the process. So some additional considerations related to implementation are the potential that the study team might provide misinformation about how to reduce risk through behavior modification. It could provide contradictory information that is the current public health response. It could provide outdated information with the current public health response. And there often is and can be a contradictory guidance from different institutions, whether they be global, national, or even institutional. Some additional offhand considerations are sanitizers can be ineffective and in extreme cases dangerous, which also might need to be considered, particularly in local contexts. COVID testing, if that's implemented, has sensitivity and specificity considerations, what the implications might be for false positives and false negatives, and any regulations that may exist with regard to obtaining PPE for participants in case they don't have, say, masks during the interview process. So just to wrap up, what all this means is I think that the mechanisms exist already for considerations of COVID risk mitigation from donors, the research team, and institutions, but it's likely to require ongoing engagement and information flows that are specific to COVID, those that are more detailed and often also more often. Thank you very much.
Thank you so much, Paul. I will kick it over to Dr. Michelle Hendon and Dr. Ruth Levine to synthesize some of these points and go right ahead.
Thank you, Corinne. And I wanted to say thank you to the three presenters who laid a lot of groundwork for some really interesting thoughts. And I think, we'll be continuing to talk about much of what has been raised up until now in the weeks and time ahead. I just wanted to sort of reflect on a couple of things that I heard, as well as maybe augment some of the points that have been raised. And I think, just from where I sit at the Population Council, this is, figuring out things as we're doing it. And it's so exciting to have a group to get together to start to really think about how we work across institutions. I think, one thing that Bilal mentioned is that we have to really think about risk as ongoing, and that we have to keep assessing it as we go through it, even as we've resumed research. And I think Paul has also alluded to this as well. I think, the pandemic as it's evolving, the biggest and most important point is that we really need to use evidence to inform our decisions and be flexible and make mid-course corrections as the pandemic changes. And I think, even though we may be able to get to a matrix and make a decision, and I'm sure we'll hear about this in the upcoming sessions, when the decisions are in place, they sort of need to be live and change as the situation evolves and changes. I think as researchers, we have both the opportunity and responsibility to innovate in terms of how and when we collect data in person. And I think for in-person data collection, evidence-based practices of how we protect researchers and the participants are really important. And it's not just the risk of COVID, but also the risk of coming into communities to collect information or coming into facilities to collect information that may pose risks to both the participant and to the researcher. I think we may also have to come to some realization that we may have to sacrifice some rigor as we think about the resumption of research. So we may have to sacrifice sample size, generalizability, and deal with some of the limitations that are being posed by phone-based data collection. And I think, or remote data collection or secondary sources, which I know all of the organizations and all of the researchers on this call have probably shifted to. But I think one thing that I thought was really important that Megan raised is that the potential inequities caused by changing how and when we conduct research is something that we should really be considering more carefully and thinking about how we quantify that and how we think about what the research means when we aren't able to, for example, access some of the poorest households and participants who don't have phones when we're doing phone-based surveys. I would love to see guidance that was clear and easy to apply, but I think we're all aware that there's really no one-size-fits-all solution, that working even within one setting that has a similar epidemiologic profile to another, it still may not be the same process, and we have to think about situational and cultural differences as we begin to resume research. And as sort of a last point that I wanted to sort of leave us with is, I think we have to consider the cost of doing research versus the cost of not doing it. And Paul sort of raised this issue around cost, but I think there's a sort of different cost that I'm thinking about. And I think we'll hear more about this in the next session, but that we're sort of talking about research and data collection as sort of a monolith, as sort of one big thing. And I think we have to be a lot more nuanced as how we talk about resuming research. Some research is related to interventions that can provide life-saving or potentially huge benefits to participants and can really change their lives. Some research is related to important questions that as a field, whatever field you're in, we may be wanting to advance, but may not be as essential. And so I hope that at some point we can get to this kind of question about how we think about research and data collection, not just as one thing, but as sort of the mix of things that it is. I'll pause here and I'll hand it over to Ruth.
Thanks very much, Michelle. Really delightful to be part of this conversation. I very, very much appreciate it. I'm just going to make a few short remarks, reiterating some of what other participants have said, but with my own perspective. So, I'm basically a kind of glass half full person, and I have managed to maintain that despite against all odds these days. And one of the things that I've observed in the recent past with all the COVID-related pressures is that there's been a real upsurge of both collective innovation, say around how to do phone surveys effectively, how to get phones to people who don't have phones, and also some collective problem solving, perhaps beyond what the global community and the research community has done in the past. And so even the experience today and leading up to today of the POP Council convening leading research institutions who are really thinking very actively about this and problem solving together is a very, very positive sign. And I know that members of the international community, the global institutions such as the Intersecretariat Working Group on Household Surveys is also very actively thinking about this and has a huge role to play. So this really is a collective action problem here, because if one group has a fundamentally different set of standards than another group, then there is the potential for a bit of a kind of race to the bottom in terms of the standards that we apply. And so I think it's really essential that we collectively come to, at a minimum, a kind of consensus, but even better would be some documented standards that we could all be applying. Another kind of positive thing that's coming out of this experience, in addition to sort of working together in ways that we may not have done before, is that we may be thinking about the safety of what I called in a recent blog post, the essential workers of the data value chain. That is the enumerators who are out in the field, out in communities, thinking about their safety and health in ways that perhaps we haven't done as intentionally before. So I think that's also a positive. A third positive is that I think there's greater pressure on institutional review boards in country to be really stepping up the capacity to assess risk and value of the data collection activities. I am hopeful that the pressure on IRBs to do things that they have not perhaps done before or not done in the same way will be met by resources from the international community to ensure that they have the ability to do that, both the technical input and also the financial resources to be able to do their work, because we really do depend on in-country IRBs to not only have the best sense of the local epidemiology, but also the kind of local political context and the value of the research that's being proposed for national and local decision making. And then the last point I'll make, which is kind of reinforces what Michelle said, I think, is that another positive of all this is that, yes, it's harder to do in-person data collection, maybe impossible in some instances, but certainly harder to do. There are higher direct costs, also higher opportunity costs. All of us feel stretched in a million directions during this time more than usual. So does everybody else in the world. And so taking people's time to respond to the questions that we may have dreamed up has a higher opportunity cost than it may have in other times. And so with these higher costs, we really have to be very, very mindful that the research that we're proposing to do and undertaking, trying to convince funders to support, that it has a commensurate value. And so I think that this kind of higher bar on for what questions is it essential to do in-person data collection is so prominent now that I think it's something that hopefully will carry over even when the costs perhaps are a little bit lower. And that may drive us to think about creative ways to further exploit the many, many sources of both remote and existing data from previous in-person data collection exercises. There is a lot of under-analyzed data out there, and this is also an opportunity to look and see what can we extract, what kind of knowledge can we extract from the data assets that we already have. So with that, I think I will turn it over to, I think it's Steve Glazerman who's next. Is that right?
Thank you. Thank you so much, Ruth, for those insightful comments. I would just like to introduce our next session. And thank you so much for Michelle for your comments, and to Bilal, Megan, and Paul for the great framing remarks. So next we're going to move on to a series of flash presentations, 5 minutes from each institution on their experiences in putting policies and guidelines into action on in-person data collection. We'll start out with two colleagues from Innovations for Poverty Action. We have Dr. Stephen Glazerman, the Chief Research and Methodology Officer, and Dr. Claudia Casaroto, the West Africa Regional Director from IPA. Next, we'll hear from Dr. Abdallah Ziraba from the African Population and Health Research Center, where he has been spearheading their COVID-19 response. Following Dr. Ziraba, we'll get to hear from Dr. Constance Mathcourt-Young, who is a research fellow at the London School of Hygiene and Tropical Medicine. Following Constance, as you can see, we have a really packed agenda. We'll get to hear from my Pop Council colleague, Leanne Doherty, who is the Senior Implementation Science Advisor for Breakthrough Research. And finally, we'll wrap up with a presentation from Dr. Cristina Palito, who is the FGM lead at the Human Reproduction Program of the World Health Organization. So now I will stop sharing my screen and kick it over to Steve and Claudia to hear about IPA's experiences.
Great. Thanks, Corinne. I hope people can hear me. So what brings me and Claudia here today is I played a key role in IPA's developing a policy to return to in-person field work. And Claudia has been very active in implementing that policy and starting to approve projects that are going into the field very soon. So IPA and sort of preparing, coming up with a thoughtful policy, did a lot of research and consultation with our peer organizations, with many people who are on this call, And so we thank you for that. We tried to create a framework for making these kinds of high stakes decisions really with imperfect information. And the information is going to continue to be imperfect, but really that would be adaptive to everything that we're learning at every level. So we're getting information from the global level, from our relationships with sort of national level government ministries where we do our work, as well as much more local level because our staff are in 22 country offices in Asia, Africa, and Latin America, and they're sort of living day to day in the conditions under which we're proposing to send people out into homes or other settings, markets, other settings where we might collect data. So how do you manage all this imperfect information? You really need a process that's going to weigh all the risks that we've just been talking about with the earlier speakers. And so this diagram with all the boxes and arrows sort of shows the way that we try to organize and systematize this process for approving projects and monitoring them as we go along, and being prepared to halt or course adjust in order to maintain a high level of safety, of safeguarding, not just of all of the actors that we talked about, the study participants, the data collectors, as well as those who are exposed to each of these in the community. So one of the things that's really central to this, and I'll talk about the light blue boxes on this diagram, is the project application form, where we came up with all of the risk areas where we feel like a project team needs to demonstrate that they've mitigated this risk and discuss how. And then that document forms the basis of a conversation with somebody like Claudia as the regional director, if it's in West Africa, for example, who would go through that and make sure that we're, IPA's institutional policy is sort of satisfied in terms of risk mitigation, balancing benefits against risks, and making adjustments to study protocols, all in parallel to the IRB process, because we recognize that IRB is important and it's necessary, but it's not sufficient in COVID era decisions about data collection. And then it doesn't stop there. We have country level review that happens just as a project is about to launch. So the project launch checklist is very detailed. It's sort of like a pilot getting ready for takeoff, the final checklist. And then finally, during field work, we insist on daily monitoring with a feedback process. And so Claudia's going to talk you through like how it's gone. Claudia, do you want to?
Wonderful. Thank you so much for introducing the group to our protocols, and let's see how we actually make this happen. As you can see in this map, we so far have approved about 30 studies. These are mostly in sub-Saharan Africa, and we're talking about rather small scale or pilot data collection activities. And of course, we're not counting the dozens of studies that we moved to remote data collection methods or that we have simply delayed. As the other panelists mentioned, we don't just weigh the risks, but we also have to weigh the benefits of doing research in these difficult times. And this forces us to be really selective about where our mission-oriented research agenda can really have the highest impact on policy and on global poverty alleviation. So let me just be very, very clear. Staff and respondent health and safety is our top priority at IPA. And research in COVID-19 times really requires completely new protocols that cost more, as the other panelists have also mentioned, and that sometimes led us to complicated conversations with our principal investigators. But let's see, what are these new protocols? Just very quickly. Training. We have moved to remote training done in small groups, and we had to divide the group of enumerators into smaller groups, and this of course takes longer and higher cost. Or we moved into remote trainings, and we could only do that thanks to the investment IPA did in remote training and remote monitoring and innovative engagement strategies for enumerators. When we get to moving to the field, we're talking about completely new transportation strategies. We call it a pod strategy. So we move in groups of 2 enumerators whenever possible, and these enumerators remain isolated from the rest of the team and as much as possible isolated from the outside, so from the wider communities. We also distribute COVID-19 supplies not only to our staff, but also to our respondents. And we are, of course, always in compliance with government regulations that sometimes refers to specifically to research, and sometimes it's more general about inter-county or interstate movements, for example. And then the data collection, very most importantly, we are very rigorous in implementing social distancing protocols, providing masks and wearing masks throughout the data collection. But we also were faced with some additional challenges on, for example, a referral process to refer respondents whom we suspect having contracted COVID-19, or even income protection for our own staff or our own enumerators to make sure that they will not feel uncomfortable in reporting to us that they are ill. And of course, we also have twice a day health checks for all of our team of enumerators, and we remove enumerators as soon as we have a sign that the health check is not being passed. So in a nutshell, in-person data collection in the COVID-19 era is possible, it can be done, but it needs to be very different from our usual way of doing business. It needs to be different in the approach, the research approach, in the field strategies, and in the budget. Thank you so much. I'll stop sharing and I'll pass on to Dr. Abdallah Ziraba.
Thank you so much to our IPA colleagues. Dr. Ziraba, I'll turn it over to you. If you can please share your screen.
Yeah, good morning, good afternoon. I'm Ziraba Abdallah. I work with the African Population and Health Research Center in Nairobi. And I'm glad to be here to share with you what, as an organization, we've been up to in terms of trying to work under COVID. And yeah, just like any other organization, APHR has ceased all in-person data collection around March, when it became apparent that there were new cases in Kenya. So that was implemented as a matter of policy, and most of us started working from home. So in-person data collection was not something that we could do. However, we continued with other research activities that we could do remotely, including desktop reviews, and other studies we could do remotely. We formed a task force, a management task force responsible for overseeing our response in terms of the overall picture of COVID and its impact on the organization, but particularly its impact on our research program. So we quickly realized that we were not going back to the old normal anytime soon. So we started preparing ourselves for working while COVID still exists. And that meant that we needed to be able to convince ourselves that we will be able to do this safely, we'll be able to do this without endangering the staff, without endangering the public, and without being unnecessary and unethical while trying to advance our own research agenda. So under this consideration, we knew that the infection transmission risk was going to be here with us for some good time. This way back in May, but we're right, we still have the problem on our hands. But we needed to continue doing research because we had obligations to funders, the public, to collaborators, and even to ourselves. We have staff that we have to keep in place, and we also have other obligations to other entities that I've just mentioned. But we also had the challenge of not knowing exactly where we're headed. The prediction of the epidemic has been quite unclear from the beginning. So the wait and see was one of the options, but we quickly realized that it was not going to be tenable. And we also couldn't just for example, fold our hands and say, well, this cannot be done, and we return the funding to the funders, or we send our workers back home. So we opted for doing research while the epidemic was ongoing, but we had to choose between either just sticking to the remote data collection exercises or trying to do in-person data collection as an alternative. In all this, we had a lot of crisis management. We had to consult with funders because if somebody has given you money to do something, you need to be able to do what you committed to be doing. And the funders were generous with information that, oh, you know, tell us what you want to do. Generous in the sense that actually they didn't have a clear sense of what to tell us to do. And we had several ideas, we had several suggestions, and most of the time they were gracious to say, well, we're okay with that change, we're okay with that change, we're okay with that suggestion. We had conversations with the collaborators. We work across the region, and there are some collaborators in different countries where the response to the epidemic were different, and the collaborators couldn't understand why we had taken the stance that we had taken. The same thing with sub-grantees. Sub-grantees have responsibilities to pay workers. They need to make the activities continue running, and they're also having trouble understanding why we couldn't take the risk and continue with the activities. Of course, there are also issues around the community. If the communities are engaged in the research process, their risk perception and their interest in continuing participating in the research in several ways also had to be managed because the understanding of the risk was quite different many times were quite different from our own. And of course, I mentioned the issue of keeping staff, but not just keeping staff, keeping them engaged so that the money the goods that they are getting out of the activity that they are engaged in. As management, Epidemiological decided to prepare for a new normal, and the decisions that were being made were, the prevailing epidemiological situation in the country, the ethical considerations, the moral, financial, and reputational risk issues. Within this undertaking, the task force decided to develop guidelines that would guide our work going forward. And this is what I'm going to talk to next. We developed a decision tree. It said, well, if you're going to do research, there must be some guidance on what kind of approach that you're going to be, that you're going to apply. We know we have a committee. We submitted a proposal to the IRB. We committed we're going to do face-to-face interviews, but probably that's not going to work. Or we committed that we're going to do face-to-face interviews, but we need to change 1, 2, 3 things. So we developed a decision tree that would guide us to say, well, if the situation is 1, 2, 3, then do A, B, C, D. I'm going to show this shortly. And we also developed a battery of guidelines to guide our work in different areas. For example, we developed a guideline on how to collect data remotely. This is not something that was totally new, but we had not thought critically through this as we did during the COVID situation. We developed guidelines on consenting and on remote data collection and how to obtain and store consent. We developed guidelines on the new in-person data collection approaches, including standard operating procedures, looking at the national and international guidelines, as well as our own considerations as an institution. Because in some cases, you could be in a situation where the national guidelines might be relaxed for whatever reason, but then as an organization, you may not be very, very confident that it's safe, for example, to send people out there given the risk that you think is still out there. We also developed guidelines on training for data collection, but also training for other purposes, because we do training as a center in many different topics. So this is the crowded picture of our decision tree that sort of guided, or is guiding actually, because this is ongoing, is guiding our work. The key element of this decision tree is the epidemiological state of a given country or given region, and the restrictions in place. The second consideration is the nature of the study And the third consideration is the local context. And within the epidemiological situation, we had 4 main issues. Consideration of whether there is local transmission or not transmission, and whether there are restrictions, and whether there is substantial risk of transmission, and the restrictions are in place. And based on those, you can make a decision on whether to go and do normal, that is the face-to-face data collection approaches, or to consider other data collection approaches, for example, remote data collection options. In terms of the nature of the study, we looked at the things that we factored in is the length of the tool. I think that one of the speakers earlier mentioned around the issue of the amount of data at times we collect. Many times the tools are unnecessarily long. We could answer the objectives of the study with fewer questions. We could answer the objectives of the study with probably a smaller sample. So those are the things that we had to consider. Do we need to study 1,000 people, or we can study 900 without necessarily reaching 1,000? Or can we study can we answer the objectives that we have with a tool of 5 pages vis-a-vis a tool of 20 pages? The other consideration was the sensitivity of the study. Sensitivity here means kind of question that you're going to ask the respondent. There are questions that are probably, if you're considering a phone interview, those questions would be very difficult to elicit good answers. So that was very important consideration. The other consideration is the respondent being able to have access to a gadget and being in a place where probably you can reach them because of the either internet connectivity or telephone connectivity. The other consideration was the need for sample collection or the need to take measurements. It's definitely difficult to do a study where you're going to do measurements or sample collection without having this done face-to-face. All this, you move on the next level and decide whether this would be possible to be conducted under the situation of face-to-face, or can only be done remotely, or if it can't be done in either of those, then that study can be pulled and it's not conducted, or in a consultation with the funder, that grant can be repurposed, meaning that you could have set out to do this study to answer 1 of 3 objectives, but because of the situation on the ground, you cannot do what you committed to be doing, and therefore you're changing the objective of the study, and with permission of the funder, that will be granted. Like I think one of the speakers mentioned something to do with, for example, using secondary data as opposed, for example, to collecting primary data. So this is what we came up with.
Yes. Thank you so much for your time, but unfortunately, since these flash presentations are meant to be 5 minutes, we need to move on to Constance in order to hear all perspectives, but we will share all the slides at the end of the meeting.
That was my last slide. Thank you
for your time. Okay, wonderful. Thank you so much. We much appreciate it. All right, thank you.
Hygiene and tropical medicine. And it's great to add my perspective to this topic alongside so many other experts who are really trying to navigate this in real time. So I'm speaking from the experience on this topic from 2 areas. So firstly, within LSHTM, I co-led and we run the collation and sharing of best practice for conducting data collection during COVID-19. And this included interviewing experts at LSHTM and collaborating partners who had experience and expertise in conducting both remote and also starting in-person data collection. And then secondly, we have been continuing running research projects in Zimbabwe, where my research is based, through a mix of remote and now also in-person data collection. And that's working with the Zimbabwe LSHTM research group. And this has included managing a range of data collection activities, including in-person participatory workshops, all conducted outside with social distancing and mask wearing, as well as both in-person and phone interviews. And it's also included the reopening of a trial of a sexual and reproductive health service delivery for young people called Chiedza, based on it providing essential services and conducting a process evaluation of reopening this during COVID. And it links back to previous points, thinking about what research really feels very necessary and important at this particular time. So I'm going to share 3 lessons that I've learned and that I think is important to think about when resuming in-person data collection during COVID-19. So firstly, I've learned that while community engagement is always a critical part of research, it gains increased importance in conducting research during the pandemic. So this increased importance is on 2 fronts. The first front is to learn from within communities to understand specific local contexts with regard to COVID-19 risk and regulations, and also what is viewed by the community as currently and locally relevant research. The second front is to garner community buy-in to research at a time when there's increased anxiety and concern within many communities globally. Secondly, the critical importance of building in structures for active listening to data collection staff or providers, including with feedback loops. So others have mentioned the importance of remaining flexible, and I think this is really important to establish this kind of listening and feedback as one of the structures within your research. So going beyond this, putting structures in place not only to actively listen, but also to enable iterative adaptation to the research or an intervention to respond to feedback received. So for example, we interviewed providers within an intervention at 2 key time points, including when we resumed in-person data activities, to hear from them about their concerns and their perceptions on how it was going. And we were able to feed this back confidentially and make changes to the intervention accordingly. And then thirdly, I'd like to highlight the importance of reflecting on how necessary adaptations to research protocols or intervention designs impacts the data that you can gather or an intervention that you can deliver. So an example from experience that I've had is that for the trial of sexual and reproductive health services for young people that I previously mentioned, social activities was a core component of the intervention, and these were necessarily removed when the trial reopened during COVID-19 to ensure social distancing. And this had a particularly large impact on the attendance of young men. So going back to the second point, having identified the impact of these changes, we were able to make iterative adaptations to the intervention within the confines of infection prevention control to respond to the challenges that the changes had raised. And so in this particular case, we added strategies to increase the mobilization of young men. So those are my 3 nuggets to think about in resuming in-person data collection. Firstly, community engagement gains increased importance. Secondly, building in listening, feedback loops and adaptation into the design of research and interventions. And thirdly, reflecting on how changes impact data and service quality. So thank you all for listening, and I'll now hand over to Leanne, I think.
Thank you so much, Constance. Leanne, would you like to turn on your video and go ahead?
Good morning, and I'll try to move quickly through here to catch us up. My name is Leanne Doherty, and I'm an associate. Sorry. I'm an associate at the Population Council, where I work on the USAID-supported Breakthrough Research Project as the Senior Implementation Science Advisor. Breakthrough Research is USAID's flagship social and behavior change research project, and I manage a portfolio of health-focused research activities based in Francophone West Africa. So similar to many of you, in March of this year, our team had just finalized 2 study protocols for evaluations in West Africa. One study was a large-scale household survey with a baseline and endline in Niger to assess the effectiveness of an SBC intervention, and the second was a qualitative evaluation in both Niger and Cote d'Ivoire. So I just wanted to kind of share a couple of experiences with our process and how it deviated from sort of norms, and then also to outline some considerations that are shaping our way forward as we navigate the evolving context. First, in the step in the process, as we had submitted these protocols to our institutional IRBs, and this included the Population Council for the quantitative evaluation and our project partner, Tulane University, for the qualitative evaluation. And we received sort of questions from the Population Council that asked that we outline our mitigation strategies and our communications with the Ministry of Health and our response related to COVID. And so we prepared a table, sort of as Paul shared, outlining how we were going to address different aspects of survey implementation to prevent the spread of COVID to the study team and the population. The Tulane University's IRB responded a little bit differently. They basically defaulted to the local IRB decisions related to mitigation. We also shared our protocols with the in-country IRBs, and we requested, as I mentioned, we reached out to the Ministries of Health to try to understand what sort of strategies they wanted us to put in place and considerations, but they did not provide us with anything specific, and they did not request any mitigation strategies during their review of the protocols. And so we relied on our institutional risk mitigation strategies in terms of thinking this through. And I think that's kind of an important point to know that sort of at the country level, this information was not available. At the same time, we were working with our implementing partners who we were evaluating and speaking with them about their activities, and most of those were put on hold from March through June, as the countries shut down, closed borders. But both Niger and Cote d'Ivoire have resumed implementation activities since July and are proceeding with basic precautions such as mask wearing, maintaining social distancing, reducing event size, etc. And this has implications for our evaluation timing because as activities continue, of course, we need to be mindful of how that would affect an evaluation. And then in terms of our donor, USAID has been very supportive, both in terms of allowing us time to consider various scenarios, how we might want to complete the activities while reducing potential risk, and also sort of being flexible in how we approach this. And so those are the sort of the steps in our process. And now I wanted to just kind of outline quickly some of our considerations that are guiding our thinking. So first, from epidemiology perspective, we're looking at the epidemiological context for COVID in both Niger and Cote d'Ivoire. They both have countries with a total population of between 20 and 25 million people. In Niger, they have registered about 1,000 cases and 69 deaths due to COVID. And in Cote d'Ivoire, they've had about 19,000 cases and 120 deaths. But of course, we don't have good data on the test positivity rate and a clear understanding of the true burden of the disease. So that sort of ambiguity is a question for us. Another important consideration is related to whether the sort of practical importance of the study. We're thinking about, in the case of both the household survey and the qualitative evaluation, we recognize that these are SBC evaluations. They have potential to provide lessons learned that can improve future SBC programs, but they don't rise to the level of importance of, say, a phase 3 clinical trial for a COVID vaccine. So we are calibrating our decisions based on this risk-benefit assessment. We're also thinking about the timing. In the case of the household survey, it's a baseline survey, and so ideally we'd want to gather data before implementation begins, particularly since the implementing partners are starting back up activities. Whereas with the qualitative evaluations, the activities were extended due to the shutdown, and so we have a bit more time to think through this process before the implementation concludes. So that timing gives us some flexibility. And then finally, we're thinking about the setting. In the household surveys, we're working primarily in a rural setting in Niger, where it'll be difficult to connect with study participants who are largely illiterate and may not have access to phones. This presents a number of challenges, both in terms of ensuring the study sample is representative and that we can achieve a reasonable response rate. We're looking into the possibility of piloting some mitigation strategies that would enable us to collect data in person. by incorporating practices such as those that have been outlined by some of our colleagues today. And then for the qualitative evaluation, we have a bit more flexibility because it's evaluating a social media campaign in urban areas. And so the study participants are in contact with the implementing partner and they're in urban areas, which helps in terms of sort of increased access to mobile phones and stronger internet connections. So basically, this is still very much a work in progress, and the research team continues to have ongoing conversations with the donor and institution regarding the considerations and steps for resuming data collection. And now I'll pass the baton to Christina.
Hi, thank you so much, Leanne, and thank you to the POP Council for hosting and organizing this important conversation. So my presentation will focus on the particular considerations around doing health facility-based data collection on a non-COVID topic, but during the pandemic. And to focus that discussion, I will present briefly a study that we've been implementing and that we've had to make some adaptations to, which relates to female genital mutilation. So in this particular project, it's an implementation research study, and it's health systems strengthening kind of approach. And we're working with primary healthcare clinics that are providing routine antenatal care services. So we're working with the providers at the routine antenatal care clinics in these countries. And this is being carried out in 3 countries, in Guinea, in Kenya, and Somalia. And I won't go into too many details, but I do want to provide a few just to give you the context of the decision making and some of the kind of lessons and some of the issues that we've been struggling with as we move forward. So it's a cluster design, so a randomized cluster design. So we have 60 primary healthcare clinics that we've identified in 3 regions, or 2 or 3 regions in each country. And we have 3 data collection points. It's tablet-based data collection. We have about 20 to 30 data collectors in each country. I should mention we're working with a research institution in each country, and we're working closely also with ministries of health at both the national and at the district levels in each of the countries. And some of the study instruments are translated in up to 11 languages. So it's a complex study, and it's one that would be difficult to carry out on in a good day. So just briefly, some of the key kind of messages and issues that we've been struggling with is, like most of us, as April was here and we were getting ready to start the study, we thought, how could we possibly do a study on something other than COVID-19 at this time? But then as we started to learn more about, and so we put on the brakes and we waited a moment. And as we started to learn that actually we're seeing a lot of cases of sexual reproductive health and rights issues increasing in the context of COVID, and harmful practices, so particularly female genital mutilation, child marriage. We also saw a rise in gender-based violence. So what we realize is not only is it it becomes more necessary for us to do research on this topic at this moment. So we felt that because this is an issue where we need to sort of identify prevention strategies that work, and one of the arms of the study really focuses on prevention in the context of FGM, we decided to move forward. Another kind of key learning that we've had, and this is obviously an evolving situation as we adapt and continue to adapt, is that the impacts on the health system need to be carefully considered. I know this has come up in other presentations previously, but that we need to, continue to provide the services. So there's a universal health coverage, there's the health system strengthening work, there's the primary health care provision. So all of these kinds of aspects are definitely a part of our study, and it's important that we continue to maintain that and support that and promote that. So it became important that we continue with this work in that context as well. Another, key kind of consideration and lesson is around partnerships, and this has also come up, but, around the ministries of health, both at the national and the district level. Sorry, somebody's coming home. research institutions in the countries, the WHO offices in the country offices, and the communities that we work with in partnership with. So, working together in this kind of partnership way enables us to make the right decisions and find the right balance of how to move forward and to continually monitor. So as everybody has mentioned, I think in their presentations, it's important of doing a risk and feasibility assessment before the research, during the research. And of course, if you're doing a scientific design versus a descriptive kind of study, there will be different risks and benefits and considerations. If you're doing a population-based versus a clinic-based kind of study, there will be different considerations as well, and so forth. But this is kind of a checklist, and I won't go into too many details in the interest of time, but just to say that, these are some of the considerations that we have to keep in mind as we decide if, when, how to move forward with the research in different settings, and that, obviously there won't be a single correct response on how to do that. And the last issue at the bottom around safety and ethical considerations, I wanted to end on that note, because that's actually the key point of all of this, is that protecting the health workers, protecting the participants, protecting the research teams. These are all the issues that we really need to make the priority in all of this, and all of the other issues we decide later. And so on that note, just to mention the study team here, these are some of these are the research teams in the different countries, and we all struggle together on these decisions and continue to. And just to thank you again, and I will stop there. Thank you very much.
So much, Christina, and to all of our panelists for sharing their key lessons learned from the field. I'll now welcome back my colleague Twy to synthesize some final lessons in this last minute that we have.
Thank you very much, everybody. And first of all, I just want to say I thoroughly enjoy the thoughtful presentation and the perspective that you have, and all the hard work that everybody have really trying to adapt to think about quality data collection during the pandemic. You've given us a lot of thoughts, and I just also want to thank the participants. We have a wide range of organizations representing, and there have been around about 250 people to 300 people on the call. So I think it's just highlight how important this conversation is. And in this conversation, we're really trying to bring in ethicists, epidemiologists, different types of social scientists to really think about some of this issue. And I just want to bring home a couple of points that presenter had made, but I also want to put out some call to action. I think somebody said a collective research enterprise. More than ever, I just want to call on the scientific community, donors, the researchers, and research institutions to collaborate. I think this is a time for us to maximize the investment that we have on research rather than working in silos. So I really think that we should find ways to cross-share some of this really important lesson learned that we consider in-person data collection during the pandemic, because it will be with us for quite some time. Another thing that I want to bring home is the dynamic environment that we're working in now and the uncertainty. So it's called for all of us to really think about localized epidemics on localized. So it's our data collection. So thinking about our collaborators on the ground and IRBs, but also thinking about the changing risk environment, as well as the different data points that we now need to use more than ever to really think about to kind of titrate our mitigation strategies or our in-person data collection strategy. A really important point that I think is so important to bring home is equity and inclusion in this era. The pandemic has brought on a heightened awareness of thinking about population who have been systematically marginalized. So are we doing research to really measure the impact of the pandemic on this population? And the secondary impact that social distancing measure that drive these people into further marginalization and suffering and poverty. So I really encourage all of us to really think about that, and that we're not typically collecting data through school, but really thinking about out of school and etc. And then I really love this point is that the frontline workers of the data collection value chain. You know, often these folks are underpaid and not well protected. So our research institution and donors of research take into account the well-being of these folks when we are considering restarting data collection. And it's really, really thinking about their well-being beyond the pandemic, and how do we ensure that we keep their well-being and their safety front of mind as they are the frontline worker in the research data collection. And then I just want to take a point to donor and researcher here is that the cost benefit and the cost of doing research in this era. I think there's so much data out there that we perhaps need to pivot our research strategy to do secondary data analysis or other type of research. And we really need to ask ourselves, one is that, would I be able to conduct research in a rigorous manner, but also, is it important enough? Is it worth it? I think Ruth really drive home that point. Is it worth it to conduct data? And is it really bringing the benefits to the community that we're trying to serve? And but we also see a lot of sloppy research during the pandemic era as well, as scientists are racing to really produce relevant data and information, but also we have to be objective and really think about if it's add value and is it maintaining rigor. And I would be remiss, but if I don't call for an open data sharing. I really believe that this is the time to facilitate open data sharing, sharing tools, sharing lesson learned across research institutions, across discipline for all of us to learn together. And last but not least, I really like this point about having consensus, a documenting consensus on how we're going to do this, and that we need to adapt that strategy. Last but not least, please continue to wear a mask and keep social distance. Thank you very much to panelists. Thank you to all participants. It's been a great seminar.
Thank you so much, Twy, for those excellent closing remarks. We will be sharing a recording of this presentation as well as slides and follow up to the really informative Q&As that were posed during the meeting. And thank you so much again, everyone, for making the time to join us for this really important and critical conversation. I hope everyone has a great rest of your day. Thank you so much.